Hello and welcome to the Tracheostomy Care Bite-sized series. My name is Andrew Foster and I've taken the content from the Critical Care Outreach team's presentation for their excellent tracheostomy workshop to bring you a series of 3 slideshows focusing on tracheostomy care. In this session, we look at tubes. So the aim for our session is to look at the indications for tracheostomy, the types of tracheostomy tubes that we use at Princess Alexandra Hospital, and also the importance of humidification. So is it tracheotomy or tracheostomy? Well, it doesn't really matter because the terms are both used interchangeably, but it's important to remember that the procedure can be a surgical event in theatres done by the ENT surgeons or done at the bedside in the intensive care unit. And this is known as a percutaneous tracheostomy. A tracheostomy should not be confused with a laryngectomy. So you can see here on the left, an opening has been created at the front of the neck for a tube to be placed, whereas on the right, a laryngectomy is where the upper airway has been surgically modified to allow the person to permanently breathe through their neck. These patients cannot breathe through their mouth and nose as we normally do, and both groups of patients are known to be front of neck breathers. So the indications may be short, medium or long term depending on the circumstances, such as securing and clearing the airway due to an upper airway obstruction or vocal cord paralysis where there may be a risk of aspiration. Maintaining a safe airway, such as in trauma or a spinal cord injury, facilitating weaning from mechanical ventilation in the ICU, secretion management in some neurological conditions, and as a part of a major maxillofacial surgical procedure. So looking at where the tube sits anatomically, we can see here on a side-on representation that the tube is in place and there's a balloon near the bottom of it here which is inflated, and we can attach a syringe to this thing here that we call a pilot cuff to do that. So like any piece of equipment, there can be problems with tracheostomy tubes, and we can categorize these into 4 main areas. So they can become misplaced or blocked. There can be problems with the equipment itself. The skills and the knowledge of staff looking after these patients can be absent. Or there's a problem within the organisation itself, limiting our ability to look after these patients effectively. One of the ways to prevent the risk of problems, of course, is good documentation. So this form will come down with the patient if they're transferred to you from critical care. And if it doesn't, you can download it from this website here, tracheostomy.org.uk. More details on that at the end of this presentation. Or you can get it from the Critical Care Outreach team as well. So onto the tubes themselves. Here is a picture of a Portex tracheostomy tube that we use at Princess Alexandra Hospital. And we can see on the pilot cuff, the information tells us that the internal diameter of the tube is 8 millimeters. And that communicates with the cuff at the end of the tube as in the previous slide. The tubes come with inner cannulas as well, so we can easily remove them if they become blocked. So let's have a look at why we need this balloon at the bottom of the tube itself. Well, really is to allow air to move from the outside of the tube and in, so it goes into the lungs itself rather than back out past the tube through the mouth. If the pressure in this cuff or balloon is too high, then it can lead to a narrowing of the trachea or softening of the cartilage, and also ultimately a fistula, which is very bad. So we need to monitor this very closely, and we would recommend every 4 hours that this needs to be done. And you can to do this, we use what we call a cuff manometer. So we attach this to the pilot cuff using this connector on the right, and that will tell us what the pressure is inside the cuff itself. And anything between 15 and 25 centimeters of water is where we want to see it. This should be measured every 4 hours. Of course, deflating the cuff or using an uncuffed tube will allow air to pass through the upper airway as well. We can increase the airflow around the tube by using what's known as a fenestrated tube, and all a fenestration is a window or a hole in the tube somewhere so that air can flow in and out of the tube, up through the tube and around the tube, and this allows air to flow even more through the voice box to allow it to retrain after a prolonged period of ventilation. With the fenestrated tracheostomy tubes that we use at Princess Alexandra, rather than just one window or one opening, there are multiple fenestrations in the outer tube. And for it to work, a red inner cannula needs to be inside it as well to allow air to pass through the voice box, otherwise it won't work. And if we're suctioning, we need to put a clear inner tube in to allow the suction catheter to be guided into the trachea to suction the patient. So what are the changes relating to a tracheostomy tube that can be a problem for our patients that we should be aware of? Well, it does bypass the mouth and the nose, and while this makes the work of breathing less, the person loses their ability to humidify and filter the air that they breathe. And their ability to speak is removed, leading to communication difficulties as well as their swallowing being impaired. They have no sense of smell, and they have problems with either coughing their secretions out of the tube into their mouth or coughing to clear. Here's a picture of how the cuff can push against the front wall of the esophagus, impairing natural swallowing mechanisms. So some patients have a different type of tracheostomy tube called a subglottic suction trachea, and these tubes allow continuous or intermittent suction of secretions that might accumulate above the inflated cuff. And here's a picture here where you can attach a syringe to this connection, and that will aspirate any secretions that might accumulate above the cuff there. Some patients might require what's known as a mini tracheostomy tube or a mini track. And these are patients who have got lots of secretions that they're failing to cough or clear, meaning that they'll accumulate inside the chest, putting them at risk of a pneumonia. So this would be inserted. It's about the same diameter as a suction tube to allow this. It can stay in the tracheostomy site to keep it paced in case a large tracheostomy needs to be reinserted. Here's a picture of one of those here. It sits in the same place as another tracheostomy tube, except it's much narrower. We've talked a lot about tracheostomy tubes, but what is a laryngectomy? So that means that the voice box has either been removed partially or totally removed, which disconnects the upper airway, the nose and the mouth, from the lungs. Once this has been performed, it's permanent, and the patient will never be able to breathe through their upper airway again. This is important. It's important to know that these patients have a laryngectomy, because putting oxygen over their nose and mouth will not improve their oxygen saturations. You should know that the patient has a laryngectomy, and again, these forms are available through the intensive care unit or the critical care outreach team, or you can download them and put them at the end of the bed through tracheostomy.org.uk. So remember from the previous couple of slides that during normal breathing, air is warmed and filtered, moistened by epithelial cells in the nose and upper airways. But a person with a tracheostomy or laryngectomy, this will be bypassed, meaning that the patient is unable to humidify the air that they breathe. So it's really important that some form of humidification is utilised for these people, particularly when they're breathing oxygen. The type of humidification required is dictated by patient need, really, because breathing cold, dry air or oxygen causes drying of secretions, drying of cilia, which impairs them, and ultimately collapse of the lungs and infection. If we don't humidify oxygen, it could result in the tube blocking, leading to obstruction of the airway, which is an emergency. So the goal then is to humidify the air and the oxygen that these people breathe, and that will promote secretion clearance, gas exchange, and reduce the risk of tube obstruction. For good humidification, we'd use a water bath humidification system, although these are frequently not available outside of critical care. They are, however, used for the high flow nasal oxygen that is used. Other types of humidification systems available to us on the wards, however, include the cold humidification system, which allow us to deliver anything between 28 to 60% oxygen, and we can attach the oxygen tubing to a special tracheostomy mask. The use of regular saline nebulizers if we need to, and the heat moisture exchangers, or HME for short, including the Swedish nose and the Thermovent, also known as the Tracheophone. These humidify the oxygen by trapping the humidity in the air that the patient breathes out in these outlets here on the left and right. You've got to check these regularly, however, as they can become clogged up with secretions, and they have a little port on the other side that allow you to deliver oxygen at low concentrations as you would through nasal cannula. So those of you with a weak stomach, look away now. Here's some pictures of the consequences of not humidifying oxygen adequately for people who have a tracheostomy. So we see one here, that the secretions that are built up inside the tube, and they can clog the fenestrations as well. For people with laryngectomy, you can use what are known as Buchanan bibs. These sit over the opening of the laryngectomy itself to trap the moisture that they breathe out, and here's a couple of pictures of them. Well, that's nearly all for part one of the tracheostomy bite size, except to say that you can access a lot more on tracheostomy care online, in particular tracheostomy.org.uk, where a lot of the diagrams from these presentations have come from. There's some very good e-learning packages there. The algorithms and bedheads that I mentioned earlier, you can download, put on the end of your patient's bedhead, and also there's lots of videos that you can access as well, including suctioning, which will form the part of our next tracheostomy bite size part 2.